at the end. If you experience any technical issues, please try rejoining the session or send a message in the chat for assistance. The session is being recorded, so if you have any concerns, please feel free to let us know through the chat. Without further ado, please join me in welcoming Dr. Afif Alangal.
Is my screen visible?
Yes, Doctor.
Okay. So very good afternoon to one and all. Let's understand about geriatric medicine in this short seminar. To make this concept really sweet and simple, I have made these slides into very in the basic simplified manner. So let's see how can we understand this geriatric medicine topic in 1 hour. So first of all, I would like to introduce the term cognitive reserve. So cognitive reserve in 1980s, Katzman described 10 cases of cognitively normal elderly women who were discovered to have advanced Alzheimer's disease pathology in their brains after their death. But they were not seemed to have clinical features of Alzheimer's disease during their lifetime. So they speculated that these women did not express clinical features of AD because their brains were larger than average. But their speculations kept on increasing. There were more researchers, and they come to a point that there is some cognitive reserve. So really, is the brain increasing in size according to our training? Yeah, they found that brain size, there is some increase in brain size. It's not the entire brain grows. There is specific part of brain, maybe in navigation requiring, for example, in London taxi drivers, some studies were found that posterior hippocampus was larger due to extensive spatial navigation training they undergo. So, is there a reserve against brain damage? The concept is most clinicians are aware of the fact that a stroke of a given magnitude can profound impairment in one patient and while having minimal effect on other. So this concept of cognitive reserve explains the distinction between degree of brain damage and the clinical manifestation of that damage. So just see this simple graph, patient 1 and patient 2. Patient 1 who is found to have more cognitive reserve and patient 2 is found to have lesser cognitive reserve. But when a damage happens, patient 2 has already reached the functional impairment cutoff. This is a brain reserve concept. So earlier it was thought the brain reserve was fixed and it didn't change with time, but it was found that the brain size, volume, synapses, synaptic plasticity, everything is a dynamic process. Whenever you train it there is a development in that, and when a development has happened and you are not training more on that, there is not much development. It can regress or decrease. So brain reserve, individual difference in brain itself allows some people to cope better than others with brain pathology. This difference can be quantitative, like brain reserve, more neurons, more synapse. So individuals with more cognitive reserves would be more successful at coping with the same amount of brain damage. So I would like to introduce some few terms so that we understand the importance of geriatrics. So the next term which I would like to introduce after cognitive reserve is life expectancy. So life expectancy has dramatically increased over the past century, where it has improved due to improving nutrition, vaccination, antibiotics, medical therapies for chronic disease. This has caused significant reduction of death worldwide. So from year 1900 to 2010, the life expectancy increased from 47 to 78 in United States. So the life expectancy at 1900 was average was around 50 now, and by 2010 it came almost to 78.7, 80 years of age. Hello. Okay. So at first, this increasing length of life result from decline in infectious disease. Then the focus was on more on cardiovascular disease, cancers. The science is targeting on how to identify these diseases earlier, how to prevent these diseases from causing more disabilities. So the future is life expectancy will continue to increase through steady improvements in reducing mortality from chronic disease. So we should focus on preventing and delaying disabilities. So when the life expectancy is being increased, there would be large number of individuals, elderly population, who are found to have multiple comorbidities. So it's the time of healthy aging. It's the time of um, actually this is the WHO's healthy aging decade. So this is the time we have to focus on how to prevent disabilities, how to maintain the reserves. So I just have introduced the term cognitive reserve. So in similar way, increasing the reserves in every aspect, every domains. Only this can enable an individual, elder adult, to live a quality health. It's not about living 100 years, uh, by last 10 years, 20 years living in the bed without maintaining your activities of daily living. Actually, we are focusing on a healthy aging where an individual can maintain his quality of life in the highest way possible. That is our aim by introducing the term geriatrics and encouraging the geriatric domains. So, what is geriatrics? Geriatric is the branch of medicine that focus on healthcare of older adults, typically of 65 and over. So, terming the making a cutoff of 65 or over. So, in the international community, in the Asian, Southeast Asian, it's considered or it's being hypothesized that aging is being accelerated. There is happening accelerated aging due to maybe the genetic composition of Southeast Asian uh, individuals. So the cutoff is kept around 60. In the West and other areas of world, it's 65. So the goal of geriatric is to promote health by preventing and treating disease, increasing the intrinsic capacity. So we would uh, learn the term what is intrinsic capacity in coming slides. So aging is very easy to identify. You can easily identify an individual is being aged, but it's difficult to define. Initially, it was termed aging is a pathological process, but now it's not a pathological process. It's a progressive process associated with deterioration in structure and function, so that an individual is more susceptible to disease and mortality. So what you see is hallmarks of aging or what undergoes in an individual who is being aged. So there is telomere attrition, genomic instability, stem cell exhaustion, cellular senescence. You can see a major demographic transition. The population of older adults more than 60. In 2015, it was 12%. By 2050, it is estimated the elder adults, the population is around 22%. So before starting our uh, slides proper. So we don't term the elder individual old as older adults. When an elder adult come to your OPD or being admitted in your ward, it's ethically correct to call them as elder adult than calling them a older adult. So let's understand the topic of chronological aging versus biological aging. So chronological aging refers how much time you have lived. It just calculate from the date of birth to current day you have lived. But biological aging defines how able he or she is functionally. It it depends on the functional capacity. So maybe two individuals, maybe for example, two individuals who are born on the same day are both are 60 years of age on today, but their functional capacity is different. It is variable. It depends on their epigenetics. It depends on their health. It depends on senescence that has happened in their genetics, inflammation, how much comorbidities they have in the current day. So chronological aging refers to the actual amount of time a person has existed, and biological aging refers to epigenetic alteration, DNA methylation, which express on how able and functioning he or she is, and whether has diseases related to old age. So just understand this concept of activities of daily living and instrumental activities of daily living. So the entire concept of geriatric is to maintain ADL and IADL till the day of our death. So maybe this is an ideal concept, but we should try to reach our dream. So ADL and IADL. ADL refers to activities of daily living, which refers to basic self-care tasks essential to care for themselves. So this is ADL. It's not, there is no I. So IADL refers to essential for maintaining independence and living safely in the community. For example, ADL is bathing, dressing, grooming. So one can live in a house by doing ADL. Maybe the uh, son or their partner can help them in IADL, but maintaining the IADL is also equally important for living in a community. So when you are living independently in a community, you should be able to cook yourself, manage finance yourself, do grocery by yourself, and manage medication by yourself. So geriatric medicine focused on promoting healthy aging, preventing disability, improving quality of life, managing multiple illness and medication. So initially, when this concept of geriatric medicine were introduced, many were talking why there is a need of geriatric medicine when there is when you have internal medicine which has reached almost it's cover when the internal medicine covers almost the entire age group of individuals, but geriatric medicine, the key difference is it not only focuses on the disease with which the individual has come to us, it focuses on underlying illness, underlying domains which are being dysfunctional, addressing that and on a preventive note, seeing the future, how to prevent these in diseases which they may found to have in the future, addressing that, how to live a quality life. This is what geriatric medicine focus, along with focusing on their current illness and medications. So, in this session, we would just go on understanding the healthy aging concept of geriatrics. So, let's understand at least this topic uh, properly. So, for better understanding of this topic of healthy aging, we will use the ICOPE introduced by WHO. ICOPE is integrated care of for older people. So if you listen this coming slides properly, you can even if you are starting your OPD in a primary healthcare setup, you can introduce this concept of ICOPE for the betterment of your elder adult. The main concept of ICOP is in the short OP time available to you, understand the declined intrinsic capacity and planning for the future. For example, if an elder adult has come to you for urinary tract infection or maybe upper respiratory tract infection, so they come to you and they have said their complaints. They have dysuria, urinary incontinence. It's being just for 4 days, but you can just screen their intrinsic capacity, identify what all are domains that has been affected, plan for. So after their UTI has been treated, you can focus on their each domains which has been affected. So this would on the when we think from the point of patient, it may be new to them. So till now they have gone to a doctor, they have asked to them only regarding their current illness. For UTI, they have given just antibiotics. Maybe they have taken done cultures, address if there is any cystitis, pyelonephritis, or any AKA, but nobody has asked them about how they are able to live in the society. How is their cognitive reserve? Who all are there for taking care of themselves? How is their sleep? How is their nutrition? So this will greatly affect their quality of life. Maybe we have to address one or two things which can greatly affect their quality of life. So let me go to the topic of ICO, integrated care for older people. So ICOPE, in the importance of ICOPE is it's a comprehensive assessment of health status for elder adults. So it maintains physical and mental capacity, and it's a proactive approach, address chronic need, not an episodic approach. It predicts if the individual is there is risk of fall in the coming days, coming months. So one of the major geriatric syndrome which we have to focus on is fall. Once a fall has occurred in a 8-year-old whose functional capacity has decreased or whose intrinsic capacity is very low, once the fall occurred, he is being bound to bed. His bones undergo resorption. His muscle undergo muscle loss, sarcopenia. He become frail. Multiple comorbidities and urinary incontinence. So it's like morbidity, mortality coming so earlier than what has been on his genes when he was born. So this is very important to predict if there is any fall or functional decline which can happen in coming years or coming months in his life. So ICOPE key guide. So ICOPE, there is 3 modules in ICOPE. So first one is identify the declining intrinsic capacity. Second one is care dependency syndrome. So there are many geriatric syndromes. So in ICOPE, we would discuss only the geriatric syndromes which would make the elder adult to be care dependent. And the third module is caregiver support. So interventions to prevent strain to the caregivers. So the first module is declining physical and mental capacity in an elder adult. So let's understand this by taking 2 cases, case A and case B. So case A, who is a 66-year-old male, and case B is an 80-year-old female. So when we When a 66-year-old male come to an OPD, when an 80-year-old come to OPD. So since it is an OPD, we are giving importance to those who come earlier. First come, first serve. But if it was a casualty, we would have triaged them. Oh, it is 80-year-old. Maybe we may do proper triaging by understanding their functional capacity or illnesses. But in a traditional way, it can happen like, oh, it's an 80-year-old. We should focus on a 66-year-old. So this 66-year-old came with multiple comorbidities, hypertension, diabetes, hypothyroidism, coronary artery disease, osteoarthritis knee. So he came with his son for with a quadrupod stick for his easy mobility for routine evaluation. He came just for routine evaluation. But this 80-year-old female who is an enthusiastic homemaker, who is non-hypertensive but well controlled on medication, she takes 2 kilometers every morning and practices yoga for almost 1 hour every day. She is an active member of local society group. She cooks every day, does her own laundry, goes out for grocery shopping, and plays with her grandchild in her free time. But she has recently noticed blurring of vision, for which she was diagnosed to have cataract in right eye and is planning for a cataract surgery and is being sent to geriatric medicine OPD for clearance for this surgery. She tells by herself that she is facing issues with her memory, which is subjective cognitive. She is telling to us she is having some issues with memory. But case A, he is not being aware if his memory is low. If his son just noticed there is some mm, there is no much issues but came for routine checkup, but sometimes he has noticed that there is some forgetting, and the son is not also not sure whether this forgetting is being a relevant issue. He has just forgotten where things were placed. So the typical pattern of intrinsic capacity. So intrinsic capacity, you can see the red arrow in an individual who has declined intrinsic capacity, and he's being more declined after significant loss of intrinsic capacity. When the intrinsic capacity is decreased, the functional ability also decreased. So to understand this intrinsic capacity, I have been saying multiple times what is intrinsic capacity. You can easily understand the concept of intrinsic capacity by seeing this picture. So imagine a tree or any plant whose root is so strong. You can imagine the root as intrinsic capacity, and the stem or the leaves or the flowers, fruits comes out it as functional ability. So when the roots are so strong, the stems erupt as or flowers erupt as good as it is. But when the roots are very weak, he or the tree is more prone to stressors happening in the environment. So functional ability is defined as health related attributes that enable to be and do what they have reason to value. So till their death, they should have the ability to do what they have reason to value. So intrinsic capacity is the composite of all physical and mental capacity that an individual can draw on. So being able to live in environment that support and maintain one's intrinsic capacity and functional ability is key to healthy aging. So what we are focused on the domain of in the geriatric medicine on healthy aging is promoting the intrinsic capacity, make as strong as it is the intrinsic capacity of the individual. So this is a positive attitudes towards health than the uh, episodic approach. It's an holistic approach in the evaluation of older person, which generate better outcomes compared to traditional disease-based model of care. So this is intrinsic capacity to understand in a lighter note. So we were discussing on ICOPE introduced by WHO. So ICOPE, so to to get more fruitful benefit from this session, I would like to understand how should you do an ICOPE in an individual. So, for example, so the person A or person B who came to your OPD. So you have decided. So person A has no much complaint other than his son told there is some issue in his memory. But you decided before assessing the memory, you decided to do an intrinsic capacity on the individual. So what are the domains of intrinsic capacity? In the ICOPS module 1, these are the domains of intrinsic capacity: cognition, vitality, psychological capacity, locomotion, sensory. So we are assessing the each domains. So identification of decline in each of these domains, what we just mentioned, is the key concept in module 1 of ICOP. So ICOP can be performed, the whole ICOP can be performed by simple step. Screening by ICOP module 1, in-depth assessment of what which domain has been affected. You should do a detailed assessment, do a personalized care plan, monitoring and reassessment every six months. So you should ask them to come to OPD every 6 months to monitor what is the current status of that particular domain, whether it has improved after our intervention, and engaging communities and supporting their caregivers. So this is the 5 domains which we are speaking. Cognitive decline. So for example, so case A, who was a 66-year-old male who came to your OPD, and you have decided to do ICOP on this individual. So you are asking to him, just remember 3 words, unrelated 3 words: flower, door, rice. And you are telling them, just remember these 3 words. So when I explain this, it's better. You understand this, like you are able to do it in your OPD. So you ask them, just remember 3 words, just register them in your mind. So I may ask you to recall these 3 words just after 30 seconds or 1 minute. So the individual in front of you just registered and repeated to you. And now you ask them orientation in time, place, person. The orientation is very important because the cognitive assessing cognitive decline will be only valid if the individuals there is no delirium in the individual. If orientation is not proper, the cognitive assessment is not correct, it's not accurate, so or it's not valid. So if the individual is able to say the orientation in time, place, person, then you can ask them, what were the 3 words which I just told you? If they are able to recollect the 3 words, so you can estimate that their cognitive domain is almost okay. Now the next domain, if there is mobility issues. So mobility, you have numerous tools to assess their mobility, like tug score, SPPB, assessing sarcopenia, frailty, gait assessment, uh, doing the bone or muscle assessment by bioimpedance analysis, DEXA, to assess the bone. You can use FRAX score to identify osteoporotic process. So the basic thing, at least you can do in your OPD, is making them to rise from the chair for 5 times. Like ask them to cross their hands over the shoulder and tell them to just tell them to sit and stand from their uh, chair for 5 times. If they are able to do it in 14 seconds, just ensure the chair you are using is a proper fixed one, not it's not a immobile or unstable condition. So if they are able to do it in 14 seconds, it's roughly estimate their mobility is almost okay. Now the next domain, malnutrition. So you can just ask them, have you unintentionally lost more than 3 kilogram over the past 3 months? If it is yes, so there is some malnutrition. This cause of malnutrition, which we can evaluate later. So for also, if there is cognitive decline in the individual as the first cognitive domain where he is not able to recall uh, words, you can keep the patient for a in the next visit you can keep the individual for a detailed assessment for cognition. So or in the second domain, if there is he or she is not able to do it in 14 seconds, you can keep them for in your next clinic. So you can keep a clinic for your cognitive assessment, like memory assessment clinic on these weekly ones, Wednesday afternoon, or weekly ones. You can keep a fall and mobility assessment clinic. So you can refer the individual to that day for detailed assessment. So these things which I am saying is on your routine OPD. You can do it in within 10 minutes. So you asked, have you experienced loss of appetite? If there is yes, you can keep them for malnutrition assessment using MNA assessing if there is any underlying malignancy, if there is any underlying infection or a chronic inflammation. If there is no anything like this, the patient may have anorexia of aging, which is also an important concept which we have to understand. How to tackle anorexia of aging and improve their nutrition. And the next domain is visual impairment. So this is very important to address their vision. You can ask if you have any problem with eye difficulty in seeing, reading, or you can keep a snell and start in your OPD and ask at least to read one or two letters. So if there is a visual impairment, it's very important to correct that, because as I told earlier, fall is one of the major thing which can impair cause deconditioning in an elder adult who is very good in his functional ability. Fall can just make him into a deconditioning manner within a day. So another domain, the next domain, hearing loss. You can ask if there is any issue with hearing, or just do a whisper test in your OPD. How to do a whisper test? Just go behind the chair where the elder adult is sitting and just whisper three letters or three words. So it's recommended. It's told letter, word, letter. Or for example, you can ask three. You can say three followed by a letter like D or F or a word. You can say 3, 11, or 3 and a word. 3 month and the third as a letter like 4 or 7 or 8. So it should be a number, word, a number, or you can do it in like word, number, or word. So if they are able to reproduce what you have whispered in behind the back, um, there is some hearing loss. We are giving this much importance to hearing loss because when you see the Lancet risk factor for dementia, so it mentions 40 percentage of dementia risk factors are reversible risk factors. In that, hearing loss contributes to almost 8% risk factor for dementia. So when you address the hearing impairment when they are in their 60s or 50s with a hearing aid or whatever the underlying pathology, that can boost their cognitive capacity. Cognitive reserve can be increased very much when you correct hearing loss. Maybe if we as like we say, visual impairment is a great boon to prevent fall. Hearing loss can increase their cognitive reserve in a very significant manner. Or you can use, actually, there is an app for this by WHO, WHO ICOPE. So you can use in that the decibel by keeping a earphone to their ear, it produces a sound of 25 decibel. If they are able to hear the sound, so they have passed the test. If they are not, we have to assess why they are having hearing impairment. And the last domain is depressive symptoms. Over the past 2 weeks, have you been bothered, feeling down, depressed, hopeless, little interest or pleasure in doing things? If it is yes, we can do a detailed geriatric assessment on depression by GDS 15, PHQ 9. So I would like to just mention few geriatric detailed assessment tool. If you have found any of these domain as affected, you can use these tools. So if the person has cognitive, he's not able to recall 3 words, you can use MMSC, MOCA, CDR, Minicog, ACE3. ACE3 is one of the standard. Addenbrook's cognitive examination tool is one of the standard tool which here we can use. Another is for psychological capacity. If there is any depressive symptoms, you can use ZDS 15, PHQ 9. If there is, he is not able to do this standing 5 times within 14 seconds, you can use a SPPB chairs rise test, assess their grip strength. If there is malnutrition or decreased appetite, you can do a detailed assessment by MNA, malnutrition universal screening tool, assess their BMI. If there is degree uh, problem with their vision, you can assess with by Snellen chart, hearing capacity by audiometry, and then proceed further assessment from this. So coming back to our case A, case A who was a retired bank official, uh, and case B who was an 80-year-old female who was an enthusiastic homemaker. So case A, after doing ICOPE on this case A, it was he was undergone this cognitive decline, limited mobility, chair rise test. So it was found that he was found to have in the step one, he was not able to recall the 3 words. So they did before labeling him as his cognition impaired, you can do a cognitive assessment in the next memory clinic by doing an MMSC or ACE3 and look his cognition if it is impaired or not. If his psychological capacity was found to be decreased, but his vitality was normal, locomotion was impaired, hearing was impaired, vision was impaired. So we had to keep a personalized care plan for this individual, and before that we had to do a detailed assessment. So he was undergone MOCA, one of the detailed cognitive assessment tool, and he was found to have score 24. So when the score is 24, and if the individual is able to do his activities of daily living, he will be termed as mild cognitive impairment. If the individual is not able to do his activities of daily living or IADL, he will be termed as major neurocognitive impairment. So his GDS, geriatric depression scale was score was found to be 9, which comes to moderate depression. His locomotion was detailed assessed by SPPB, which was found to be 6. So we have to assess on why he is having decreased mobility, why he is not able to do chair rise test properly. Hearing, his audiometry test was found to be he was having moderate sensory neuro hearing loss, and vision was 6 out of 18, 6 by 18. So there is a significant loss of intrinsic capacity. This individual came to our OPD by son just saying he is having some occasional misplacing of things, but we have found these domains has been impaired. So a routine blood work was done, and on he was found to have grade 3 osteoarthritis knee. For that, we can easily in these stages we can give exercises to keep the knee strengthened, maybe local topical applying anesthetics. And on cognitive assessment we can do TSH, vitamin B12, if there is any hyponatremia, and a brain imaging. There was a chronic lacunar infarct, and his B12 was found to be normal. So the overall impression is he's having a mild cognitive impairment. Why we are saying as mild cognitive impairment is because he's able to maintain his activities of daily living, and he's having moderate depression, impaired mobility, impaired hearing, and his hypertension was uncontrolled. So personalized care plan was uh, prescribed to him. Like, since it is mild cognitive impairment, we don't need to prescribe any medications for that, like acetylcholinesterase, no need of that. You can advise them cognitive exercise, which cognitive exercise will coming to coming slide. And for moderate depression, you can give take the help of a clinical psychologist who can do a uh, psychological counseling. When they are not amenable to counseling, you can give SSRIs in small dose, which are SSRI which are friendly to elder adults. Some SSRI like sertraline can cause hyponatremia and fall in elder adults. So the one of the safest is estelopam. Then you can, for osteoarthritis knee, you can strengthen their knee uh, muscles by doing physiotherapy, and you can give them a hearing aid, then optimize their comorbidities, hypertension, and physical activities, and advise them to do physical activity. Now the case B, we also did a ICOPE on case B, and was found she was saying she was having a problem with her memory, but that was just subjective cognitive decline. On cognitive tool assessment, her cognition was normal, vitality no, commotion, hearing was normal, just the vision was impaired. So since one domain is only affected, we can term her as declining intensive capacity. Since she told she is having memory impairment, we did uh, TSH, vitamin B12. So it was found there was some mild vitamin B12 deficiency and vision impairment, which can be addressed by a cataract surgery. And she is having only subjective cognitive impairment. So the personalized care plan which was put forward to her was vitamin B12 supplementation, continue her antihypertensive, cataract surgery. Since there is subjective cognitive decline, we can give cognitive exercise to them. Now, the main domains of ICOP, we will just brush up through what we can do in each domain. So mobility loss, if there is loss of muscle mass, muscle strength, decreased flexibility, this individual can easily get bound to wheelchair. But if you start exercise according to their tolerability. So when you term exercise, it's not just walking, it's not just aerobic exercise, it's strength training exercise, balance training exercise, and flexibility exercise. So you can start appropriate exercise according to after assessing which intervention they need. So if there is mobility, if some of the recommended things are protein intake. So almost 1 gram per kilogram is the recommendation of protein intake if an individual elder adult is found to have decreased mobility. Enhance exercise along with giving protein in diet. Then when you advise them for aerobic exercise, you should be able to provide them a safe space for walking. Even in the house they are living, easy uh, uh, easy availability to the house facilities, in the even outside the house, in the community, you should be able to provide them local facilities, good services. Then these are the different types of exercises, as I told. The second one, as it's showing aerobic exercise. The first one it's showing balance training, and the last one is showing strength training exercise. Oh, and the second domain, malnutrition. So in aging, it is associated with progressive decrease in body weight and increase in fat mass. So you can address that again by giving proteinaceous diet and exercise. So if there is decrease in, along with age, there is decrease in taste of, smell of food, poor oral health, you can address them by giving, if there is no enough taste. So we have seen many individual elder adult who has found with difficulty to pass bowel movements. Uh, and after detailed evaluation, it was found there is nothing significant. There is nothing underlying malignancies or ulcerations. They are not able to pass because there is no enough fiber in their diet. This was because there is no proper dentition. So when there is no dentitions are not good, you can provide with them dentures for to include enough fibers in their diet. If there is any loneliness, depression, it can lead to malnutrition in the individual. So engage or eat together with the elderly in the house, then keeping them, giving them food into the separate room, and make the food palatable to them rather than giving every day the same food. So who do not consume enough protein are at increased risk of developing sarcopenia, then osteoporosis, impaired immune response. So also for malnutrition, you can ask what were the food they have taken in the last 24 hours, so that after getting what were their last 24-hour intake, you can advise change in that diet. How protein can be introduced, plant-based proteins or animal-based protein if it's appropriate their culture. Assessment of muscle mass, muscle strength by this is Jama's hand dynamometer, which has cutoff of 18 in females and 26 in males up in the 60 to 70 age group. And look for potential, along with assessing malnutrition, you should also look for any underlying gross rapid weight loss, swallowing problem, chronic malabsorption syndromes or medical illness. So if the individuals are not able to dine with the family, maybe the family is abroad, you can consider social dining for elder people who are living alone, which can greatly improve their appetite and great change in the status of malnutrition. So other recommendation is include small frequent meals which are protein and energy dense. Emphasize their favorite foods in palatable textures. Add herbs, spice to combat reduce taste or smell. Enrich with healthy fats like olive, butters, protein and calorie-rich drinks. Consider supplements which can, like in a single food itself, which can provide maximum proteins and calories. Than giving it them a tea with biscuits, and encourage them to take these foods and give in a more flavored manner. So in visual impairment, as we told earlier, age is frequently associated with loss of vision, and most common loss of vision is cataract. For that, community case finding is an very good provision, and referring them to their nearest district hospital where governments can provide them free cataract surgery, so that even government can think like when this individual vision is not being corrected, he or she come in the future with fall fracture, which is a huge finance burden for the government. So the government can intervene earlier by because I say this because most government policies are being programmed by thinking how much cost effectiveness it can provide. So visual impairment, you can provide affordable spectacles if it can be corrected with spectacle under, if there is any glaucoma address it is in the earlier stage itself, not waiting into the advanced stage of glaucoma where it cannot be done anything. Then occupational therapies. So in some cases, we may not be able to give medicines or surgeries. So in those cases, for their vision, you can provide color contrast in the home, promote safe mobility within the home. So vision aids like magnifiers, large print, voice-assisted devices. For example, if an elderly adult who is sleeping in a room at night, he has to go to bathroom. There is in Amazon there is Alexa provided lights uh, which can uh, on the light according to the voice of the elder adult. Like these voice assisted devices. So, other than that, as I told earlier, the environmental modification, color contrast, modified tasks to enhance visual accessibility, like using tactile labels, large print voice assisted device. Now, hearing loss, this is very important. Maybe sometime when we understand the concept of cognitive reserve, we may think hearing loss is to be addressed more than anything else. Because as you can see in this slide, this is the risk factors provided by Lancet, which is in this S shape. Hearing impairment is leading to almost 8% reversible causes of dementia. So untreated hearing loss affects communication and contribute to social isolation, loss of autonomy with associated anxiety, depression, cognitive impairment. So this is one of the largely undetected thing in the community and untreated. So social isolation, loss of autonomy, it leads. So sometimes simple interventions can be provided, like fitting hearing aid, environmental modification. Like whenever you talk to elderly, uh, talk in an environment which is like having less background noise. When you talk an elderly in a background which is having heavy noise, it leads to their anxiety. They may think, why I am not able to cope up with uh, the society. It leads to depression and anxiety and more problems. This has to be done when you are not able to provide proper hearing aids or cannot understand what is the underlying hearing loss, or the individual is not able to undergo a procedure which can uh, increase their hearing.
Hello, Dr. Afif. Dr.
Okay,
Afif, just a
okay,
reminder, we have another 20 minutes to go because
okay,
students have a class onward. So I would just
okay,
suggest, I think it's doing very, very well, so extensive, but
oh,
just go towards like concluding with some, important points. So
okay,
you have some time for the question and answer. Thank you.
okay, okay. I will. So we will complete the slides in uh, like few slides only. So hearing loss recommendations, we can use community case awareness, any ototoxic medications, address that. For cognitive impairment, address the underlying cause. What is the cognitive impairment which is causing them? If it is Alzheimer's dementia, Lewy body dementia, whether it is Parkinson dementia, frontotemporal dementia, what is the underlying cause? Identify that. Uh, so these are some cognitive exercise which can be provided, like encouraging them to play card games along with their peers. So newspaper recall daily, this can be done. Chess, playing chess, uh, we are not aiming at they play chess games and doing good in that. We are just ensuring to stimulate their cognitive capacity, to ensure neuroplasticity. This is our aim in doing that. So whenever they are seeing TV or reading newspaper, a caregiver just asks, "What are you seeing?" Trying to do active recall. So depressive symptoms, as I told earlier, address that in the earlier stage itself. Otherwise, it can lead to maybe it started as depression. It may go to the advanced psychiatric illness in future. So this were module one of geriatric. and then module 2 has got lot of geriatric syndromes. Like these are all geriatric syndromes like immobility, incontinence, falls, polypharmacy, delirium. So one of the important is urinary incontinence, and identify what is the urinary incontinence, are stress, overflow, which is the incontinence causing them, and uh, identify the underlying problem which is causing incontinence. We may not need medications in every incontinence. Maybe some pelvic floor exercises, like in males, maybe gas holding, females, Kegels, and males also can do Kegels exercise, modifying their drugs. Maybe some diuretics you can uh, keep it in the early morning, bladder patterns, keeping a bladder diary, modifying that, and risk of fall, identifying if it is an extrinsic factor or intrinsic factor, if there is any postural orthostatic hypotension, if there are any improper lighting in the house, ill-fitting footwears, rugs, if those are present, you can modify that. You can modify the bathroom, which can be elderly friendly bathrooms with a grab bar when they get up from the bathroom. The tiles in the bathroom, which can be anti-slip type uh, anti-slip type tiles, assess their gate. If there is any gate issues, like if there is any magnetic gate which can be seen in Parkinson, magnetic gate which can be seen in NPS, fascinating gate in Parkinson, or if there is any hemiplegia, if there is any gait impairment, address that. You can provide aids to for mobility. And if the risk of fall, what is the underlying risk of fall? If there is an osteoporosis risk, address and manage it. Don't be hesitant to give bisphosphonate after correcting the calcium, vitamin D, and checking the serum creatinine. If there is renal dysfunction, you can go with denosumab or whatever. The module 3 is caregiver support. The caregivers are facing huge stress, uh, which are also not addressed. So you can give if the caregiver is providing care to an elder adult, you can give help with another caregiver who is a relative, or can be provided from the society itself. Non-governmental organization can provide some caregiver for at least 6 or 4 hours a day. During that time, the primary caregiver can do whatever they can do with their life. Their life should not be ruined just by taking care of their dear ones. So caregivers of people with severe declines in intrinsic capacity are high risk of experiencing psychological distress. So home-based respite care, where another family member or suitable person relieve the main caregiver to rest or carry out the other activities. And one important thing is involving this caregiver in the decision about life and care as much as possible. Thank you. You can proceed with any questions.
Okay, perfect. So thank you so much, Dr. Afi, for such an insightful and interesting talk. I think a lot of us today learnt about a wide variety of factors that need to be considered when treating our elderly population, our aging population. And I thank you so much for coming along and sharing your knowledge with us today. It's been incredibly interesting. So now I'd like to open up the session to a Q&A session. So as I mentioned earlier, please feel free to unmute yourself and ask any questions that you may have to Doctor. If you otherwise also can type your question into the chat box and I'll read it out to him as well. We have both options, so please feel free to ask any questions.
Thank you, Aisha. Would you mind if I can ask the question directly to the speaker?
Yes, of course. Go ahead.
Okay, Dr. Afif, it was one of the very extensive session in which you highlighted many of the basic knowledge beside a lot of extensive stuff which is really needed, and it was a good recall for also me after a long time. So my question is, actually what I feel, we do have the years lived with disability, YLDs, right? So
Yeah.
which are mostly focusing on non-fatal health conditions. So, can you please highlight, because normally when we are talking about the current topic of interest, like how we deal with the YLDs, number one. Number two, what I understood from entire stuff is one of your slide, which is more on long-term exercise versus a short-term exercise kind of thing, can really affect the quality of life, right? So, how you relate this YLDs versus the long-term, short-term exercise, looking at the limitation. This is my one question. And second question, I think better ask both of them together. Second question for me is, especially in the people with, like, like our cases, our Asian cases, Asian people, they have a different level of vitamin D consumption, for example, right? So we are unable to basically come up with our cut off yet for so many things. So how to incorporate that part of the metabolites, targeting the current era of genes and proteins, because yes, for sure, the Caucasians, even they have a water, what we call the sun bath, even for few hours, and they got an issue. And for our people, they're normally under the sun, right? So this is my second question. Thank you so much, and hope, inshallah, it was a good session, hopefully to align in many things with you in the future.
Okay. So the first question was regarding the exercise thing. So regarding exercise, as I told, as I shown in slides, this exercise should be started considering their what are their prior comorbidities, how is their tolerance, how is they are able to cope up with each exercise which we are being able to provide. So it should be given in like dose by dose, giving the small dose of exercise. If an individual uh, who is having difficulty in as our patient case A was having osteoarthritis knee, so we can start with simple exercise which can increase the strength of quadriceps, which can reduce the limitation in mobility, and then increasing with step two of exercise, then increasing with the other modes of exercise which can enable them with uh, their life. Another exercise for balance is Tai Chi exercise. Tai Chi exercise is more focused on enabling their balance, so that when the balance is being ensured, if an individual who has been undergone Tai Chi exercise training, even if there is small environmental hazard which they can have in their life, like a wet floor, they, they may be able to cope up with the uh, 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 fall imbalance which they can have, uh, like when they were in a younger life. And one question was years of disability. Uh, so for this disability, they have facing in their life, what we can do is one of the main important program which we have been doing in our institute in Delhi was to decrease the disability life. One of the major thing was incorporating the elder adults in the uh, activity. So even if the elder adult who has been retired at the age of 60, for example, if he or she is a was a retired professor, who was a retired teacher, who is a retired businessman. Businessmen don't retire, so even if it's a retired driver, include them. So these individuals were taken in the healthy aging community was created, and they were being taken into the schools in various areas. So in Saturday afternoon, one individual were asked to take a session on practical session on what profession they were being involved. So disability uh, uh, we have to reduce the disability in which we are having by we can increase the cognitive reserves in the individuals and address the declining intrinsic capacity. Only then we can decrease the disabled life or disabled daily in the coming years.
Thank you so much. Thank you so much, Dr. Afif. Okay, one more question. Can you comment on the caretakers who are basically, involved with these kind of patients with YLDs, and especially geriatric followed by the YLDs? So I think caretaker have a lot of challenge to take over, right?
Yeah,
So I think they also need a kind of, from my point of view, they also need a very strong kind of psychological interventions all the time.
yeah. So regarding caregivers, what happens routinely in, for example, if a patient is being admitted with CVA, and the patient is having risk for aspiration, and we have just put them on a nasogastric tube and advise them, okay, this should be changed every 3 or 4 weeks. So we should understand so one major thing is we should tell them how to feed, how much nutrition is required. For example, this patient is going to face severe loss of protein in coming days, coming months, in the till he get recovered from his illness, or maybe he is not able to get recovered. So the, as I told earlier, the diet which is being provided should have at least 1 to 1.5. So earlier it was asked how much protein. So the protein intake should be on how much capability, functional ability, or muscle loss which we are anticipating, or how much muscle loss is being occurred. According to that, we should give the protein. For example, 1.2 to 1.5 gram protein. If there is renal impairment, we should not give this much. It should keep to zero point 0.8 gram per kilogram. So this much protein we are giving, we are advising them to feed the individual through the nasogastric tube in 45-degree. Do not make the individual to lie down immediately after the feeding. So we are explaining everything to the individual, and what happens is we tell them change the position of the individual every 2 hours. Otherwise he will get bed sore. Keep an air mattress. So when we are telling this to a primary caregiver, in which house he or she is living, uh, tell them to give at least their 4 or 5 sons or relatives who are related to them. When they are all available, you should explain these things, and you should advise them. You should not burden the primary caregiver with these things. Every day at least 6 or 8 hours should be provided. You can give, if there is no sons or relatives available, you can provide them from uh, geriatric home nurses, or NGOs who can provide voluntary nurses, or who can give with like minimal financial support, who can give these facilities to the major thing is the primary caregiver face is they face huge. There is one tool called Kingston Caregiver Scale Tool, from where we can understand how much stress they are facing and give. So the term scale uses Kingston's. So from this we can understand how much stress they are facing and give the needed psychological support on the day of discharge of the elderly individual, not after 6 months or 1 year, where they are already overburdened with the stress. On the day of discharge of caregiver itself, we should start with the steps which can address this caregiver stress and caregiver burden.
Thank you so much, Dr. Afif. Actually, I've been working a lot with the molecular interventions in the past for this kind of topics. Okay, one of the my commenters, what do you feel if, like, the spike model? I think very famous spike model, which is normally to break the bad news to the patients for the tip,
Yeah.
take the people who are taking care of the patients, caregivers, and everyone. So if we change that surrounding of the S, which is basically the surrounding, which we feel in some of the cases we brought in, like example, if a patient is a Buddhist, we brought in a monk. If it's a Hindu, we brought in the pandit. If it's a Muslim, we brought in one scholar, to align it in a very positive way to break that the surrounding more comfortable. So I think this model of spike, in which bringing the S part more towards spirituality, could increase the level of metacognition of the patient, empathy, sympathy, everything. So this is one thing we have been working currently. Hopefully, I think it could be good. Just want to add this comment, and thank you so much again for your answers. Thank you so much. Thank you, Aisha.
So, as sir told, we are also we were following this, bringing spiritual leaders in various, when we were in Delhi. We were most were Hindu population in the, and we were able to bring some Swamijis for the help of this. So actually, we can introduce this thing at the end of life care thing, which is has got great, which can introduce great quality of life, not only to the patient but also the caregivers. So that's a very important thing, and I'm so happy that it's being followed in your place.
Thank you so much, Doctor. We actually have one more question since we have a little bit of time. So, Doctor, we wanted to talk about how in Malaysia we often have elderly individuals living at home, and they often have maids or house help that assist them with their daily activities. And as you mentioned earlier during your presentation, the importance of maintaining independence and functional ability amongst the elderly people. So, how would you suggest we maintain that balance between independence as well as household, like help and daily household activities? How should healthcare providers and family caregivers assist in such situations?
Okay. So, how should a family take care? So this we can start from the time when he gets up in the morning. So whenever he wakes up in the morning, maybe he is waking up at 5 a.m. or 6 a.m. So what all we should use, the since it's the world is in the modern age, we should try to use all the modern facilities which we can give to the elderly also. As I told earlier, if there is a voice provided lights, if it is not available, you can give the switch we can, of the light should be just near to him, so that when he is waking up he can just on the switch without, before getting up itself he can on the switch. And the light also, light should be, there should be two patterns of light in the room which he is sleeping, dim light and bright light. When he is going to sleep it should be a dim light. And the house environment should be properly maintained or properly kept in the hygienic way, so that they don't get confused with which, where is the individual rooms. For example, if a elder adult has got five sons, so they have decided he will be living in this month, he will be living in this house. Second month, he will be living in the second son's house. So this may create, if there is a cognitive decline in the elder adult, this may create more confusion in the elder adult if we change the house every month. So this is another way. So keeping the same house, the bathroom, so that it won't create fall. Maybe if we shift to another house, the next day he may think this bathroom and go to another house, and it can create more embarrassment. So if we stick to one house, keep a light in his near to his fingertips, and the facilities are near to him, most facilities which can be provided like this. So if a light is kept near to him, you can avoid the maid to do this thing, like waking up activities. You can avoid this. And another example, after waking up, he is brushing with his teeth, brushing his teeth. So at that time, for example, if the individual is having Parkinson's disease and he's greatly suffering from tremors, so you can just either modify the brush, like custom made brush which is having more weight. For example, if they are eating, if the hair goes more tremors, make the spoon which has got more weight type of spoon. When you ask them, the individual people who make spoon, you can tell them to provide with spoons which has got more weight, or you can give 3 or 4 spoons tied together. It will add weight to the spoon, so that tremor frequency, if it is in this frequency, it greatly reduced the degrees frequency, so he is able to eat by himself. So the maid has a less role in that, just of monitoring in him. So maid is making to do more of monitoring activities. If he is able to do it himself, maid is asked to give him the corresponding instrument which is able to do by himself. Only then he or she will have enough confidence in doing thing by himself, or to live further years of life. So in like this, in every activities, so after eating, if he is going to bathroom, so the bathroom should have a handheld shower. So the handheld shower, which is being he can use by himself, the stool where he can sit by himself in his chair. So then, if there is a maid in the house, she should be advised. He should be able to go to the bathroom. He should be able to. He is made to use the handheld shower by himself. Like this, in every activities, uh, making them to do independently. And if we are keeping a maid, he or she is being able to monitor his activities only in the maximum possible way, and help only if it is required. So that is the concept of uh, introducing how to maintain the independence of instrumental activities of daily living, and using a maid or caregiver along with this. So we can use this in every activities. There is one or another way for this.
Perfect. Thank you so much, Doctor. I'd like to thank you again for coming today and sharing your knowledge with us, and giving us a lot of advice and help into how addressing our aging population. Was very insightful. Thank you so much. I'd like to thank everyone else for joining today as well, and we hope that you found the talk interesting. Thank you.
Thank you. Thank you for this opportunity to interact with this wonderful community. So I am so happy that you are doing many things in your hospital. So it's my pleasure. Thanks.
Thank you so much. Thank you, everyone. Thank you, Aisha.
Most welcome, Prof.
Bye.